So what I was talking is, I'm going to talk about mitochondrial diabetes. This is maternally inherited diabetes and deafness. Though the name was coined in 1997, we were aware of mitochondrial dysfunctions and some of them presenting as diabetes. I remember Dr. Sushil Jindal presenting his case in exam as Mela syndrome, which we are going to discuss after this. So why to discuss about maternally inherited? Because it is the mother who gives you everything. Fathers keep something in reserve, but mother gives you everything. The mitochondrial DNA is exclusively maternally inherited. All offsprings of the affected mother inherit this genetic defect because ova, but not the sperms, contribute mitochondria to the developing embryo. Only females pass it to their children. So if a given female is having mitochondrial dysfunction, she passes it to all her children, but only girls will pass it to the next generation. So it appears in every generation of the family and can affect both males and females. In general, mitochondrial diseases are very heterogeneous group of genetic conditions, very variable in phenotypic presentation. They have multi-system involvement. Basically, they are group of diseases which are produced because of decrease in ATP generation. So they are energy deficiency diseases associated with defects in respiratory chain complexes. There is increase in the oxidative stress, uncoupling of the membrane potential, and tendency to lactic acidosis. Now, there are many mitochondrial diseases, but some of them have great predisposition to diabetes mellitus. Some of them I'm naming here. First is maternally inherited diabetes and deafness. Then there is MELAS, that is stroke-like episodes, lactic acidosis, congenital decline in cognitive decline, seizures. Then Kearns-Sayre disease, where there is progressive external ophthalmoplegia. Pearson disease, sideroblastic anemia. Mingy syndrome is a GI motility disorder. CPEO is chronic progressive external ophthalmoplegia. MERRF is myoclonic seizures with cerebral ataxia. Leber's optic neuropathy, you know. So in short, what I'm trying to tell you, that mitochondria being essential organelle of every cell, and many processes are dependent upon the energy level. There are many variant manifestations. Mitochondria are the powerhouse of the cell. They produce ATP. They produce it by oxidative phosphorylation, and they have reactive oxygen species generated through the electron transfer chain. Their mitochondria is important for production of ATP, and ATP is an important thing which produces the pancreatic beta cells to function. When glucose is ingested by the beta cell through the GLUT2 transporters, it is converted in the Krebs cycle to produce ATP in the mitochondria, and then the ATP is sensitive, potassium channel closed, calcium channel open, and you get insulin secretion. So ATP level is very important for the normal functioning of the beta cells. Mitochondria have their own DNA, and several copies of that DNA are present in the mitochondria. Mitochondria has a circular DNA of its own which governs 37 genes. In contrast, its own proteins are regulated by the nuclear DNA. There are more than 20 mutations known to be associated with diabetes. The most frequent is this one, mutation 3243AG. And this is about 1 to 2% of all type 2 diabetes probably belong to MIDD, or maternally inherited diabetes and deafness. Now you should know something about homoplasmy and heteroplasmy. When all mitochondrial DNA molecules within a cell are identical, this situation is called as homoplasmy. And when there are 2 or more mitochondrial genotypes, that means one has mutated, then this is called as heteroplasmy. And the ratio of wild or natural to mutated determines the onset of clinical symptoms. A minimum critical proportion of mutated DNA molecule is required before biochemical deficiency manifests as clinical phenotype. So this threshold level varies differently in different mutations and even in different tissues. And therefore, some tissues manifest more disease. Functional consequences are commonly seen in those tissues which are most dependent upon the energy, that is muscle, brain, and heart. They use more energy. Now, this particular mutation of maternally inherited diabetes and deafness, this is the most frequently associated mitochondrial mutation and is associated with numerous clinical syndromes. And you should be aware of all this to pick up the mitochondrial diabetes. There is mitochondrial encephalopathy syndrome with lactic acidosis, stroke-like episodes. The classical is the maternally inherited diabetes and deafness, and less commonly, myoclonic epilepsy with ragged red fibers. Now, what happens? The heteroplasmy in the circulating leukocytes goes on decreasing by 1.4% per year, and therefore collecting urinary epithelium from urine, freshly passed urine, becomes important for analysis of the DNA. Now, this is common thing which you know, that when the glucose is taken up by the beta cells, it is important in producing mitochondria, or it is providing, you can say mitochondria produce ATP from this, and the potassium channel being sensitive to ATP closes with this, and then the voltage gradient causes opening of the calcium channel, and influx of the calcium causes insulin secretion. Now, the slightly opposite process is going on in the alpha cells, and therefore glucagon secretion is not affected in mitochondrial diabetes. So here is the interesting situation. You have got defective secretion only of insulin, but preserved secretion of glucagon. We'll come to the discussion about this in the treatment part. Now, mechanism, what exactly causes diabetes? So as I said, there is impairment of insulin secretion. And as the age of patient goes on increasing, the heteroplasmy in pancreas or beta cells goes on increasing. There is loss of beta cell volume due to apoptosis, activation of SIR3 kinase or serotonin by threonine kinase activity inhibits the glucose transporter also, glucose transporter 2, so that the ingestion of glucose into the pancreatic beta cell also goes down. So this causes decrease in the secretion of insulin, and the oxidative stress also contributes in many tissues to impaired insulin signaling, causing a sort of insulin resistance. So there are a variety of factors which contribute to insulinopenic diabetes in MIDD. The usual presentation is at around 37 years. This is a mean age. So anywhere between 15 years to 70 years, people have been reported. And as Sandeep said, that you can diagnose MIDD even at the age of 60 years if you are not aware of it. Low BMI is a very important clinical feature. So most of the obese people will not have MIDD. This is maternally inherited. So you must have, as Sandeep again stressed, a good family history, and charting of the family tree should be there. Pre-senile sensory neural hearing loss, which precedes even by a decade, is very important pointer. And other abnormalities like cardiac conduction defects like WPW, then sick sinus syndrome, proteinuria, neuropathy, pigmentary retinopathy, all they point to the associated mitochondrial disease. This first is type 1 diabetes, then type 2 diabetes, and then MIDD or mitochondrial diabetes. Age, if you see, mitochondrial diabetes usually present in the middle age, somewhere between 30 to 40, average age 37. They are lean, they are never obese. They are insulin dependent, no doubt, but only 8% actually present with ketosis. They are at risk of ketosis. Type 2 are not at risk, they are resistant to ketosis. Type 1, of course, present at they are ketosis prone, and they are insulin dependent right from the diagnosis. Mitochondrial diabetes initially can be treated with oral hypoglycemic drugs, but after about 4 to 5 years, most of them start requiring insulin. C-peptide is undetectable in type 1, high due to resistance in type 2, but is inadequate and then progressively goes on decreasing. Autoantibodies are never positive in mitochondrial diabetes. Neuropathy and nephropathy can precede the diagnosis of mitochondrial diabetes because they are part of mitochondrial dysfunction. But once diabetes starts, then their deterioration increases because the glycemic control affects the neuropathy and nephropathy even in the mitochondrial diseases. Nephropathy is type of the focal glomerular sclerosis type. Interestingly, pigmentary retinopathy of mitochondrial dysfunction protects them from proliferative diabetic retinopathy. Of course, additional features like deafness, WPW syndrome are important and you should look for them. Treatment will go into the discussion, but it is an important thing. So I stress it again here that metformin is not the drug of choice in treating mitochondrial dysfunction because you can precipitate lactic acidosis. Even in pediatric age, people have published recently from Italy about 30 patients between 20 years identified. Their age at onset was 11 years. Ophthalmic manifestations were more common than the hearing impairment. Their weight was normal. Fasting glucose A1C were high. Fasting C-peptide was nearly very low. Creatine kinase was slightly high, suggestive of myopathy. Interestingly, autoimmune presentations like thyroiditis, celiac disease were also common. Maternal history was less, but when tested for the mutation, then 91% of the patient's mother also had the same mutation. The prevalence of peculiar macular retinal dystrophy was found to be present even in adult patients. 85% exhibited bilateral macular pattern dystrophy, linear pigmentation surrounding macula and optic disc. It can be picked up by the ophthalmologist, but you should inform your ophthalmologist what you are looking for, not routine diabetic retinopathy. The prevalence of diabetic retinopathy was actually reduced. So diagnosing pigmentary retinopathy is also important clue for you. So how will you diagnose mitochondrial diabetes or maternal diabetes? It is maternal heritability of diabetes or impaired glucose tolerance or gestational diabetes with normal BMI, hearing impairment even before diagnosis of diabetes, and detection of maculopathy after. So keep on following, and every year you'll get more and more patients showing maculopathy because maculopathy is affected by the glucose intolerance. Now, variety of presentations are there. The old textbook picture of short deaf patient with diabetes is nowadays rare because these were the patients who were very severe mitochondrial disease with multiple abnormalities and encountered at, you can say, different centers even before the diabetic centers could pick them up. So when do you suspect? When should you suspect? A thin type 2 diabetic patient diagnosed at around 35, 37 years with poor response to metformin, with little bit exaggerated response to sulfonylurea. There's a family history of maternal family history of pre-senile sensorineural deafness, especially so if combined with diabetes and other conditions like cardiomyopathy, WPW syndrome, six-sinus syndrome, epilepsy, ptosis, recurrent stroke. So each of these additional features adds up weight to the growing suspicion of mitochondrial disorder, over response to sulfonylurea and poor response to metformin, progressive decrease in beta cell function, and ultimately requiring insulin. Metformin, if at all you are going to use, you should monitor lactate level after starting metformin and after about, say, 3 to 4 weeks after starting metformin to see doubling of lactate levels. High index of suspicion. So a maternal family history of deafness and diabetes is elicitable in 60% of patients. It is true that only family history of diabetes is not very much suggestive of mitochondrial disease, and therefore pedigree analysis is very, very important. You should, in such patients that is diagnosed at middle age, maternally inherited, associated with deafness, and BMI low, you should have pedigree analysis put on the first page of the case paper. Deafness is usually present when diabetes is diagnosed. Audiogram should confirm it if patient is not ready to accept it. A variable number of additional features should be found out, and regular ophthalmological assessment in diabetic patient will give an opportunity to identify pigmentary retinopathy, which gives additional support to your diagnosis. Approximately 20% of the patients present acutely, 8% of them may be suffering from ketoacidosis, but only 13% of patients who actually carry this mutation are insulin requiring at the time of diagnosis. And though their presentation is insidious, once they present, they start deteriorating fast. And in about 45%, within 5 years, have become insulin dependent. Autoantibodies are negative. Fasting C-peptide can be used every year to predict who are going to be insulin dependent soon. Their BMI is low, and this should always be remembered that a low BMI indicates earlier diagnosis and multiple multi-system abnormalities. Neuropathy and nephropathy can precede the diagnosis, and once the diagnosis is made, they can further progress also. But retinopathy, as I said, starts deteriorating or getting picked up, especially macular retinopathy will be picked up after diagnosis of diabetes. Same is about cataract. And therefore, after the diagnosis, every yearly you should have a detailed ophthalmic evaluation. The beta cells have metabolic dysfunction. They start having apoptosis, and the C-peptide levels start going down. Their heteroplasmy level is high, and ultimately they become insulin dependent. Therapy-wise, how will you approach these patients? Majority of the patients, at least 85% of the patients, when they will be diagnosed, they will not be dependent on insulin, and therefore you will have a choice between gliptin, sulfonylurea, and metformin. So if I may suggest that metformin in a patient with low BMI, where there is a suspicion of mitochondrial diabetes, should not be the drug of first choice. Sulfonylureas can sometimes throw the patient into hypoglycemia because they are very sensitive to it, and therefore a gliptin can be started, or a very small dose of a short-acting sulfonylurea can be started. Emergence of newer drugs is being investigated in many centers. For example, SGLT2 inhibitors are highly, interesting because they don't produce much hypoglycemia. They have additional cardiorenal protection. But as I said, this particular pattern of diabetes has slight hyperglucagonemia, and SGLT2 inhibitors are also known to produce hyperglucagonemia, and therefore the predisposition to ketosis or euglycemic ketosis remains. So you have to be careful, and when you are starting the patient, but with good care, you can give them cardiorenal protection with this drug. So as a second-line drug, you can always use SGLT2 inhibitor. GLP receptor 1 analogs also have got very attractive hypothesis behind them, because in experimental animals, there is reduction in the mitochondrial stress and apoptosis. There are cardioprotective effects. Only thing is that they have incidence of pancreatitis, and there is increasing, nearly doubling of retinopathy in semaglutide trial sustained. They also produce weight loss, which is already, they have lost weight and they are at low BMI. They can, GLP-1 receptor analogs can unmask GI features of the mitochondrial disease like hypermotility. But still, in some of the centers, they are preferred therapy under observation. You can use it, but be careful. Coming to metformin, there is poor response to metformin. Theoretically, it increases the risk of lactic acidosis. It inhibits the mitochondrial glycerophosphate dehydrogenase and decreases hepatic gluconeogenesis. But still, people have advised that you can use metformin if they tolerate, and you can go on using it up to the GFR of 30 also. But you have to monitor serum lactate every 3 to 6 monthly. Now, interestingly, what is the beauty of medicine is that you get everything you get a surprise. So today morning only I read an article which came in 9th August 2021, that is last month, in the journal Antioxidants and Redox Signaling. Now this article is about type 2 diabetes induces mitochondrial dysfunction. Now this is not primary mitochondrial dysfunction which we are talking about, but metformin improves mitochondrial function and function of immune cells and decreases atherosclerosis in those type 2 diabetics who have developed mitochondrial dysfunction because of the diabetes. So this is the interesting part of the story. In general, you should avoid valproate, barbiturates, tetracycline, chloramphenicol, aminoglycosides, and metformin in a suspected patient with mitochondrial dysfunction. Transplantation in these patients, because there is no underlying autoimmune process, this becomes an interesting, case that progression to end-stage renal failure is more in mitochondrial diabetes, and therefore they are more candidates or susceptible candidates, or you can say good candidates for kidney transplant or kidney and pancreas combined transplant, and the possibility that there is no autoimmune process and therefore there is less chance of rejection in theory. What should we do about statins? Because statins are known agents which can produce some myopathy, myositis, but since they are life-saving drugs, it is argued that you should assess pre-treatment creatine kinase levels and repeat them periodically. But you should give advantage of statin therapy to these patients. You can give it with coenzyme Q10 if you want, because basic mitochondrial disease has been treated by variety of agents. I think I remember coenzyme Q was being given in the dose of 100 to 300 milligram in some of the patients where mitochondrial dysfunction was suspected. But I don't know what happened to them later on. No much literature about it has come. People have given it for statin-induced myopathy, but not directly for mitochondrial myopathy. Variety of amino acids have been tried, B complex vitamins have been tried. So in summary, this is a multi-system disease. This is not only isolated diabetes. So you should be aware of cardiac, renal, nephrological, and neurological, ophthalmological presentations. You should do audiometries and ophthalmological investigations. You should have a pedigree, and you should always be having high index of suspicion in patients who present at the middle age, type 2 diabetes-like presentation, initially non-insulin dependent, low BMI, but rapidly becoming insulin dependent. These patients are most likely carrying the mitochondrial diabetes, and from pedigree you can suspect it, you confirm it by variety of other investigations, and then you decide the treatment. Thank you very much. I appreciate Dr. Jindal and Dr. Khare and his team for organizing this type of symposium, and I have loved this. I have learned a lot. Thank you very much.